Top-Bed Talk.
I'm David Walker. Welcome. Optimising the delivery of care is the theme. First, Natasha Curran, consultant in Anaesthesia and leads our pain management centre at University College Hospital. She's on the NHS England Pain Reference Group. She writes nice guidelines, and when she's not doing that, she comes here to Dingle to tell us about her latest experience. And our second speaker, again, a friend and colleague, Mark Hamilton, is a consultant practicing in intensive care and anaesthesia at St George's, where he's an honorary senior lecturer. Mark, I think it's fair to say you've been here from day one at EBPOM, perhaps, being on the board of directors. But you've had a busy last 10 or 15 years of your career, where Mark has been involved in commissioning healthcare and latterly a significant leadership role in his new job as an executive director in the Surrey Healthcare Board. Thanks, Mark. Our final speaker then needs little introduction. Dr. Anna Batchellor is consultant in anaesthesia and critical care medicine in Newcastle, probably known to most of us as the past president of the Intensive Care Society and now college council member. Anna, I heard you speak at Health Education England last week, where you talked in an animated way about healthcare practitioners, which I know has been vexing you for the last 5 or 10 years and taking a lot of your energy. I think the only thing which has stood in the way of your retirement in the last couple of years, as you tell us, is this thing called getting it right first time. So I'll ask all the panel to come and join me for a moment. While they're taking their seats, can I just get a show of hands? You in the audience, do you define yourself as primarily as clinicians, i.e. Coalface workers? And if so, raise your hand. Great, thank you. So to the panel, there's the first problem. Everybody in the room, apart from one or two, define themselves as Coalface workers. 3 great bits of work, fantastic. How do we get it across to the guys who turn up every day to do good clinical medicine? What are the barriers? What are your plans?
Well, I'm hoping that intensivists are as competitive as orthopaedic surgeons. I think every clinician gets out of bed wanting to do a good job in the morning. I think very few of us come in going, it's awful, I can't be bothered, blah, 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 blah. And I'm hoping that there is something positive in being offered information about your unit where you're either doing well, maybe not so well, some hints about how you might change it. I'm also hoping that maybe I can support people a bit in that I suspect that some of the money that comes out of orthopaedics or any other branch of surgery that's being done more efficiently should be spent on different parts of the pathway. So I think there should be more of that money that goes into the perioperative pathway and more of it should be going into critical care, but I could be biased just a little bit. But it's a total package of money to do something. Is it entirely there to buy fancy hip replacements, or is it there to look after the whole patient's pathway? And I think people might buy into that, but I don't know.
Well, you want to kick back at that from the audience? Problem as I see it is doctors are in charge. We put doctors in charge of these things. And my experience is that all doctors want to be important. Nobody wants to be useful. Would it be better off if we got other people who turn up every day to be in it for the long game, fix it for patients, or just have these journeyman doctors run it and move on?
I think you're hitting on something there, David. It's about culture, isn't it? And if doctors aren't on side, then things generally don't go well. There's lots more barriers put up. So I would say, in answer to your first question, it is about, that was referenced in Mark, it's about building relationships and being present, providing support in whatever way that might be, whether it's change support, QI methodology, and really, I think one of the things that you do have when you come from you're a clinician background is you have empathy for that. So show it and provide something that you can to do something that makes a difference for those clinicians they've got to do the day job as well as trying to do your shiny new project. So how is it relevant for them? What will they get out of it?
Sure.
I'd just add to that to say I don't think you can shortcut the conversation.
Yeah.
We can define, and so we took a way of going to citizens, first of all, with that citizens engagement model, and said, we're going to do this. What do you think about it? How does it land with you? Is this the right thing for us to be doing as a system? And then every single piece of work we did, everything we embedded, we got them there. We asked their opinion. And actually, I think you've got to close the gap between what you're asking people to do and what really matters to them on the ground. And that's a bit of appreciative inquiry, and it's going there and listening. And if they ask for help, we know it's always going to be, I need more staff, I need more money. But you've got to reframe that question into something that actually impacts for them and is meaningful for them. And that's a relationship, that's a conversation. That will never be a command and control bit. And some of our medical model, I think, is changing. And I think we will have a flatter structure going forward. Doctors will always be important in that. But I think to get effective work done, we need to embrace multi-professional leadership.
Ross Kerridge, Newcastle in Australia. Mark in particular, but any of the others, you touched on the triple aim as one of your goals. Now, some people have suggested that there's a fourth aim of improving the experience of the people actually working in the system. And it's also been suggested the fifth aim is population engagement and support for the health system. I think in Britain, it has been shown that the British population supports the NHS over and above any other health system anywhere in the world. So that's not a problem. But I was surprised you didn't even touch on improving the experience for the staff, be they doctors, nurses, or any of the people who really do the work, like the cleaners.
So that's we have a core program of work going through that is based on the IHI Joy and Work program. But where our engagement bit comes from and our joy from working comes from is that we've set ourselves an ambition to be an anchor system. So each of the bits in the organisations within it, we want to be anchor organisations. And if you don't know what that means, that essentially means that they are key bits of your landscape when you grow up that you want to be associated with or you will come back to because they are good places to work. And part of that is developing the right culture about how you get work done. And we all know if you make life and work easier for people to do, they'll want to come back there. And there are various things we're doing in terms of the passporting between professionals in the system to say, well, actually, you work for Surrey Heartland, so you don't necessarily work for Ashford, St Peters or the Royal Surrey. And if you want to go and you want it, and it makes your carbon footprint more sensible to work from that organisation rather than this organisation, then we'll do the right thing by you to make that happen. And because of the changing infrastructure we have at the moment, we've made a commitment that we won't lose good staff. So lots of people are worried about their jobs because of the changes that are happening, and we've made that commitment that we would not lose them.
And I might just add to that is that one of the things that the Health Innovation Network does, just as patient experience, so all of our projects, we have a mechanism that on our project management that the patient's thought about each part of the project, and the same thing goes for staff. So, I completely agree. It's the double helix, the DNA of care. Unless we have good staff experience, we know that's one of the greatest determinants of patient experience, and not just patient experience, patient outcomes.
And from the GERFT point of view, orthopaedics is significantly further along, and it's very interesting hearing orthopaedic clinicians who have taken ownership of this within their units. So they are looking at individual surgeons' outcomes within their team and saying, well, your outcomes were not so good for this, so do you want to stop doing that, or do you want to start doing more of that, but we will work two surgeons together to improve your skills? And it's trying very hard to actually empower clinicians to do their job better by having the data to enable them to do that. And I was really impressed that surgeons didn't go out for the kill on each other, that they're actually talking about working together, because I know some who would, quite honestly.
So has the profession of being a doctor changed, and should we care less about Ehlers-Danlos and the clinical signs and more about teaching how to manage, organise and structure this sort of workload? Is tomorrow's doctor looking more like that person than an Ehlers-Danlos doctor? Ramani.
There's a bit of that, but there's also a bit about enabling more people to have the opportunities that you three have had and I've had and others have had to spend time, which is what we all lack, doing these things. You don't have to do it full time, but you do have to do it in more than your 2 SPAs while you're trying to do everything else that you're doing. Yeah. And yes, I think we need to think a little bit more about, it doesn't have to be every doctor. Every doctor has to achieve a level in, QI or teaching and all the rest of it. We all understand and agree with that. But we don't all have to be experts at the sort of thing that you three are talking about. But we probably do need to give more people the opportunity to branch into that. And we are shrinking back those opportunities, I think, and that's really, really hard. And I think it's probably why there's a disproportionate number of people who go through, for example, academic routes that are in senior management positions, because that type of portfolio career gives you the time to do these sorts of things. And we need to redress that, because we need more frontline clinicians who want to do it to have the opportunity, and I don't think we're creating it.
Got it. There's a question here, then.
I think is a huge issue is data. The first part of any meeting I go into is a big squabble about whether that they have no idea how many cancel. I don't think they have any idea how many anything happens. There's all, you go to a meeting to discuss something and data's put on the table and it's unrecognisable in terms of what you actually do. And I think until we can improve the quality of data that we generate locally and then gets fed further and further up, GIGO, the more garbage we fire at the centre, the more garbage comes back. And I think there's a fundamental issue around the data we generate, and we need to get that right before we can start doing anything useful with it.
And I think we're right in the middle of that conversation with the regulators at the moment to say, what value is this to you and us, and us generating it? Because it's a constant source of argument. If it's meaningful outcome data and it's the right outcome data, then we should have a proper discussion about it if we're not doing it. If it's markers of process that just tell us that we're not getting to the right outcome data, I'm not sure that's a very meaningful conversation currently.
You'd have these massive
You'd
have these massive forms come out with riddled with what I used to call just in case data. Yeah. We can measure that, so we will just in case it turns out to be useful. And I think we need to get rid of a lot of just in case data, and we need to focus on getting the core stuff. I mean, we're not talking subtle. We're talking about how many people live and die, how many people stay for so many days. I mean, it shouldn't really be that hard. But actually, I think what we generally generate is rubbish.
Dave, can I just come back on that? I think the other important point about anything to do with change or improvement is that you've got to work out what you're going to stop doing. You can't keep piling it on top.
Hi, I'm Anne-Marie from Torbay. It's mostly for Mark, really. With the
where are you? I can't see you. Sorry.
I'm up here. With the increasing number of devolved healthcare systems we're likely to see, and given that we're a perioperative medicine conference, what advice would you give to perioperative clinicians doing the job day to day, like most of us are, to harness that change and be able to embed some of the initiatives that we need that start out in the community and go all the way through, the circular relationship back into the community?
So I think it's interesting, and Natasha and I were talking last night about it, that actually the AHSENDs are very focused on supporting STPs and ICSs and devolved systems, because that's where a lot of the work will go going forward. And I think perioperative medicine, because I think we are quite forward-thinking as a speciality, I think we're quite vocal as a speciality going forward, and I think we're quite broad-reaching, that I think perioperative medicine getting into the big clinical pathway bits with the devolved systems and putting some straw men and women in place so that it makes sense, so people can see the connections. And then it goes back to our old hemodynamic days of monitoring, that hemodynamic companies were always in the business of education, not about supplying bits and bobs. Sorry if there's any sponsors in the audience, but that's kind of where it was. And I think maybe for perioperative medicine, that's our role, is to supply that educational piece and then the improvement piece at the back end of it to deliver it. And a lot of the stuff that RAMS is doing nationally as well.
This came up in Dingle last year. I think there were several sessions about it, and perioperative medicine being much earlier on in the pathway. So what you'd hope is that, I don't know whether the commissioning will continue as it is now, but what the ask is for something different, which again relates to outcomes. And then our position as perioperative anaesthetists is not this person decides to have surgery. It's what treatment plan did this person need, and actually if surgery is the answer at the point at the end, then you're not seeing that person when they've had. When the decision is made to have surgery, you're seeing them as part of the workup beforehand. And I think some of the talks this afternoon will address some of those things as well.
If there are no more questions, I could take one more before 12:30. And if not, I'd just like to ask you to join me to say thank you very much to the speakers.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.